Our last speaker, Hemi Tewarson, will share how governors and states are working together to approach this epidemic. Governors are at the forefront of efforts to curb the opioid epidemic and its related challenges, and the National Governors Association Center for Best Practices team has been leading efforts for several years to share best practices and strategies to address this public health challenge. Hemi is overseeing many of these efforts in her role as the director for the National Governors Association Center for Best Practices Health Division. She has decades of experience in healthcare policy in the public and private sectors, serving as senior attorney for the Office of the General Counsel at the U.S. Government Accountability Office, and in private practice as a health policy attorney. Hemi, thanks for being with us today to offer a state perspective and share NGA's efforts, and I'll turn it over to you.
Great. Thanks so much for having me, and it's really a pleasure to participate in this webinar. So I will talk quickly because I know we're running short on time, and I want to be sure there's some time for questions from the audience, since I see there's quite a few. So just very quickly for you all who are not familiar with us, the National Governors Association is completely bipartisan. Our current chair is Governor Bullock from Montana, and our vice chair is Governor Hogan from Maryland. And we've been around a long time. This picture is the first time the governors convened in 1908. But I'm going to keep going because I'm going to talk about opioids today. You go to the next slide. One thing I do want to point out about our work is that we work, so I lead the health division, but we work in complete partnership with our public safety, Homeland Security and Public Safety Division, because really the public safety folks have been on the front lines of seeing what's happening with the opioid epidemic. So we really make sure that all of our strategies when we work with state leaders and with local communities really encompasses both the health side as well as the public safety side. So I just wanted to be sure to share that with you all. Great. So I'm not going to talk too much about this slide because I think Carla did a wonderful job with the data that's really identifying where we are going on this epidemic. I did want to just reaffirm that we are seeing this directly from the states. Certainly states are seeing synthetic opioids really taking off in terms of the deaths, as well as the psychostimulants that are mixed with the synthetic opioids. And so that's really going to continue to be the challenge, especially for our states out west. And I think their question is, how do we think about, the opioid money that we're getting from Congress and thinking about redirecting it to these new challenges? So I think that's going to continue to be a conversation from a policy perspective. Okay, so just to give you a little bit of sense of kind of where we've been in the National Governors Association working with governors on this, we've really been working on this since 2012. Governors have been, unfortunately, having to lead the charge on this since that time. It continues to be a priority in their state, even with the, the new substances that are coming into play. And one of the things we did in response to that was the governors signed a compact to fight the opioid epidemic in July 2016, and they asked us to come up with a roadmap. And so if you're interested, this is on our website. It really is about how states should think about strategies across the three spectrums of prevention, treatment, and recovery. And I think, Ken just provided some really good insights on kind of what he's seeing from the plan perspective in Massachusetts. And Carla, of course, looking at the federal strategies, and we all are working together on this, but we are certainly focused on how states can partner with all these different entities to figure out a way forward on these challenges. Okay. So I wanted to just show you where we are with states, where we have been, where we are going in terms of state work. And I'm not going to be able to have time to talk through all of these, but I thought we could highlight a few of them for you. In our work with states, I don't think any one state has solved this. But what we have tried to do in our work is highlight where are places where states really need additional support, and are there models within those areas. And so what I thought I might do is just talk about a couple of these. One is how we've been thinking about improving access to addiction treatment in rural areas. Another big area that we are working on is how we really get medication-assisted treatment for justice-involved populations. So I'll talk a little bit about our work on that. We are doing a heck of a lot of work on addressing infectious disease-related substance use, so I'll talk about the projects that we've had going on there. And then how do we really think about non-opioid pain management? So, I think Carla touched on, and Ken as well, about sort of script limits and thinking about how to, on the prevention side, really, get a better handle on how these are being prescribed in the forefront. But then the question is, there are people with chronic pain, and what are those alternatives to treatment? And we've certainly heard from different folks with pain and pain advocacy organizations that have really been clamoring and saying we are not getting the help that we need, and so what are the alternatives? So I did want to talk a little about the work in that front. Okay, so what have we been doing for addiction in rural areas? So in our project that we highlighted for other state leaders, we really looked at New Mexico. And I wanted to spend a minute talking about New Mexico and their work through their TeleEcho project. We hosted a learning lab with 3 states so they could learn about what New Mexico is doing, and they have been working on this since 2005. And what's really, I think, helpful to understand about what New Mexico is doing is they realize they don't have enough behavioral health providers to actually get those folks across their states. And so what they need to start relying on is what are video conferencing technology and clinical management tools that can be beamed out from a hub, essentially, where they have all the expertise to those rural areas where they don't have that expertise. And that's really what they've been doing. Since their initiation, there have been 950 patient cases that have been presented in the virtual clinics and 9,000 hours of CME logs. So certainly been significant uptake of this strategy. And they've also really required their Medicaid managed care organizations to get involved, paying specialists with per member per month funds, and also recognizing the role of the primary care physicians who present. Okay, medication-assisted treatment for justice-involved populations. So Massachusetts, so Ken, your state, was the state that we modeled for this. And really, there is a reentry initiative that's a partnership between the Department of Corrections and the Department of Public Health in Massachusetts. And it was implemented in 2014, and as it has really increased access to community-based MAT, especially from those coming out of the prison systems to communities. We brought 8 states to learn about what Massachusetts has been doing, and really I think there is now a new movement towards inducting treatment upon transition into facilities post-arrest, so really making sure to get the treatment to folks when they're coming out of the facility so they don't go back in, because it really is a revolving door. One of the things I did want to highlight, because of the interest in this topic, we are doing more work now, actually this week, where we're hosting trainings with 9 states to help implement action plans around MAT in correction settings, especially focusing on continuity of treatment and care linkages to social support services and communities. So if you're interested in that, there will be more work coming out from NGA and the states on that front. Okay. Infectious disease. So that has been a big topic for us. Injection drug use drove a 350% increase in hepatitis C between 2010 and 2016. So we really saw a need to really do some work on this. Kentucky was our model state, and they were the first other state to authorize comprehensive harm reduction, which included syringe exchange. And now syringe exchange programs have been approved in 60 of Kentucky's 120 counties. Pretty impressive. They really did that with partnering with their local leaders, fire chief, police, religious leaders, to really make sure that the communities embrace this concept. And although there's only preliminary data, they have so far provided over 180 referrals to substance use disorder treatment and completed over 1,700 tests for hepatitis C and over 2,300 tests for HIV. So we have 2 briefs on this topic if you're interested, talking about Kentucky specifically and the 7 states that learned from them on our website, so feel free to follow up if that's an area of interest. We also will be launching a new program on this, focusing on New Mexico, because there really is actually a lot of interest from states on this topic. Okay. Wanted to talk a little bit about pain management. So I do think this is an important part of the conversation. This is just a snapshot quickly of the limits. There's 33 states that had some sort of statutory limits on the prescriptions of opioids. 15 states had 7-day limits. This is certainly most common and follows the CDC guidelines. 4 states had 3 to 4-day prescription limits. This is more rare. And then there's 7 states where they directed other entities to set prescription limits. And then there was some of those states, just a few of them, 4 of them, set dosage limits, where they actually looked at the milligram equivalents or MMEs. So that's just a snapshot of what the states have done on that. But I think what comes next, and this is really just a continuum of how states are thinking about it, is, okay, you're limiting the first-time opioid prescriptions. There are exceptions, of course, for certain types of chronic pain and cancer and that sort of thing. But then there's also, how do you promote the clinical guidelines for safe prescribing? How do you think about transforming pain management in and of itself? And then how do you expand access? So I think these are the 3 areas where we're going to work on as we move forward. And just very quickly, I think we talked a little bit, the presenters before talked about, and Ken in particular, about acupuncture, and there isn't a lot of evidence necessarily on these structures, but states are starting to experiment. So I just want to highlight quickly that in Ohio, in their Medicaid program covering acupuncture and chiropractic services, and then in Rhode Island, they have Medicaid communities of care where they're providing access to chiropractic care, acupuncture, massage therapy, along with access to nurse case management. I think the takeaway from this, and we will have a paper coming out on this as well if this interests you, is that states are stepping in gingerly and carefully in terms of the coverage of these services, sometimes only for certain indications like low back pain, because it's not completely clear on the evidence. But I think there's a real interest in figuring out how do we have alternatives to opioids to actually help people with their pain. And with that, I think I'll turn it over because we are running short on time. So thank you, Catherine.